you know, the clinician of today versus the historical role of the clinician. You mentioned sort of this broader care team and the importance. Are we doing enough to train the clinician today to think about care teams, to think about these other resources, or what do we need to do to make sure that?
Yeah, I mean, I think it's starting. You know, in medical schools, there's more interprofessional training where budding physicians are working side by side with other team members and learning that that's the way to deliver care. But again, there's no way to the old notion that the physician is the person that's going to do everything is just impossible. And you go to any primary care provider and they're overwhelmed. And the answer really is to be more team-based and work with other members of the team and have everyone practice to the top of their license. And it's a more satisfying job for the people involved, and it allows more touches to the patient because, you know, for the person with diabetes, it's really not about the 3 or 4 or 5 times or even 6 times visit to the physician. They need more touches to be able to keep them engaged, and you know, because adherence is a challenge, and some form of self-management support is really critical.
So how do we, John, how do we pay for that? You know, Medicare, I guess, given the results of the study, has determined that there's some benefit in terms of the investment in new payment models relative to the expected outcomes. But representing a health plan, how are you guys thinking about this?
So on the managed care side, in the government-sponsored space, we offer case and disease management programs that are interdisciplinary teams that partner with the provider. For example, we may have a pharmacist, a nurse, a social worker, a community health worker who helps us locate our members in the community who have diabetes and connect them to those resources. So that is a benefit that we offer our most vulnerable at-risk members. In the commercial space, it's usually offered to the employers as an add-on benefit as part of the coverage they provide to the members in their panel.
Mm-hmm. Great.
But the dilemma of offering it to the most at-risk individuals is that 2/3 of Americans are overweight or obese. 1/3 are obese. And so this has to be something that reaches the overall population. And by the time people are at greatest risk, when they've developed already high levels of risk factors or they have existent cardiovascular disease, of course they still need this kind of intervention, but we really want to get them before that time.
Absolutely. Yeah, the focus should definitely be on prevention. But I think when you're working with limited or finite resources, you want to target those resources to the most vulnerable members that you can impact and make a difference with the onset intent of lifestyle modification and enforcing the importance of improved quality.
Right. So Michael, as an endocrinologist, and hearing that the primary care world is taking care of the bulk of diabetes patients, maybe talk about how that relationship between endocrinology and primary care is, and maybe where you see it need to continue to develop over the past and also or in the future. And if you could also talk a little bit about the comorbidities and complications associated with diabetes, including cardiovascular risk.
Sure. I think the role of the endocrinologist now is to take the most severely affected patients, to take the most complex patients, and to tune them up and return them to their primary care provider. But we also need to be reaching out. You know, I work at a medical school, so we also need to be reaching out to the primary care providers and providing education on the fundamentals of diabetic care. And those include, as you mentioned, the associated complications that go with diabetes, the hypertension, the dyslipidemia, and then also the complications of diabetes. You know, the complications of diabetes break down into 2 fundamental categories: the microvascular complications and the macrovascular complications. The macrovascular being primarily heart disease, stroke, heart failure. And so we need to be addressing those with different interventions, which I think is some of what we're going to talk about.
Great. Anybody else want to comment on that?
Well, I might just comment a little bit around the ways in which specialists can interact with primary care providers. I think I think the new model where we see lots of examples of is, as specialists, as endocrinologists, we take care of the highest risk patients and the most complex patients, but we can guide primary care in how to deliver better care for the vast majority of their patients. And I think, in essence, we have a responsibility to do so. We have this specialized knowledge that we want to transmit. And that's not just us, it's diabetes educators going into primary care, dietitians, other folks within this concept of the medical neighborhood. Primary care being a series of medical homes, and the medical neighborhood being all of the rest of us that are outside of primary care but need to guide primary care to enable them to do a better job.
Well, exactly. Well, actually, we have a program at the University of Missouri where we are reaching out once a week via teleconference. Yeah, I was going to say via teleconference. And so we have primary care providers calling in from all over the state with de-identified cases, and then discussions with our endocrinologists of, okay, this is how I would handle this case, at least in theory, and also providing very short segments of fundamentals of diabetes.
But I'd like to bring up one slightly different version of this idea that there are different complications, and this is that there are probably different gradients of the relationship between diabetes and outcome of different complications. And so for microvascular disease, certainly diabetic retinopathy, really we see it occur in its real manifestations in the frank diabetes blood sugar level. With neuropathy, it's a little bit less clear. It may occur at much lower levels of glycemia. And with macrovascular disease, there seems to be a continuum of risk from levels, let's say fasting glucose, below 100 milligrams per deciliter, still above the population average, going all the way up through the diabetes spectrum. And so there has been this controversy of what is the target, and we still don't have an answer. But we have to be aware that starting very early in treating glycemia, treating diabetes, certainly will track in many ways with improved outcome.
So that's a good segue into kind of our next section, where the scientific evidence for this disease has really advanced quite rapidly, particularly probably in the past 10 or 15 years or so. So results from the SPRINT trial, for example, suggest that controlling blood pressure more aggressively may be better for high-risk patients, although it's unclear the implications for diabetics. And new ADA guidelines reinforce strict glycemic control for seniors. So not only is there evidence, but some of the evidence is targeted to specific patient populations or segments of the diabetic population. And I guess a general question for you all is, how are clinicians in the world dealing with this scientific evidence as it comes out, and are we getting it kind of from bench to practice? Do we know how to get it to practice?
Well, I think one of the things that makes it more challenging, and I'm sure we'll get into this, is that there's controversy. One study suggests one thing in one population, another study looks at a somewhat different population, maybe less power to see differences, and doesn't see differences, and there's a need to interpret all of that information, and particularly as we're saying that most of the diabetes cared for by primary care, they've got diabetes and asthma and CHF and many diseases. And diabetes hasn't, it's complex, and it's not so simple to say, just do this. Do this when this, but sometimes think about that. And it's, I think, really, the best guidelines are more nuanced and need to be as we individualize our care.
I think one thing that is common, though, is in both, whether it's the ADA or the ACE, the American Association of Clinical Endocrinologists, the goal is to get the HbA1c as low as possible without causing hypoglycemia. So whether that's 7 or whether that's 6.5, ultimately we have seen tangible benefits from a clinical outcomes perspective to having a lower HbA1c.
Absolutely.
And that's unanimous. And so however we can empower the clinician and the patient to get there, that's really our charge.
What about in the area of hypertension? And Zach mentioned the SPRINT trial. maybe your thoughts on that. I know there's some suggestions about whether guidelines should be updated or changed, the patient population that was included in that trial, and so some question about the implications for diabetes.
Right. So the SPRINT trial is just the latest in a succession of trials of blood pressure goals for people with diabetes, and in the SPRINT trial, non-diabetic persons. And we go all the way back to the United Kingdom prospective diabetes trial sub-study of hypertension, where the comparison was 155 versus 145 systolic, and showed tremendous benefit in terms of reduction of heart failure, of cardiovascular outcomes, of retinopathy, essentially across the board benefit. So fine, but now we've moved past that. In 2008, we had the report of a very large, important trial, the ACCORD blood pressure sub-study, which compared a blood pressure of around 130 or so systolic versus a blood pressure of around 120 systolic in individuals with diabetes who had high cardiovascular risk, most of them with either a lot of risk factors or already with disease, and most of them with a decade of diabetes. And the trial was a surprise because it didn't clearly show benefit of the systolic of 120 as opposed to 130. And that led to a lot of discussion. And actually, the American Diabetes Association took a step that one might say is backward and said, well, maybe 140 is okay for a goal.
The strongest evidence being there for 140, right?
But the reality is that if you look at specific outcomes in ACCORD, stroke was reduced much more at 120 than 130. And so in a population where stroke was more common, actually ACCORD blood pressure would suggest that better goals are needed. On the other hand, renal function worsened at the lower blood pressure, and so that's a different population, different targets maybe are appropriate there. So now we come to SPRINT, and in SPRINT, the control population was at 140, and lo and behold, in this study of people who did not have diabetes, it looks like, again, lower is better. There's a meta-analysis that just came out among people with diabetes showing very similar evidence that systolic blood pressures lower than 130 may be better. So my understanding of all of this as a clinician is just we need to truly individualize blood pressure treatment goals as we do with glycemic goals, lipid goals, etc., in treating the individual, very carefully watching their renal function, being cognizant of what their risk is. If it's someone who's had a stroke or someone with a strong positive family history, then we might aim lower. If we treat someone and we notice their creatinine rising, we might have to back off. And so it is nuanced, and unfortunately, as Einstein said, keep everything as simple as possible, but not too simple.